Good morning, everybody. Today we will continue part 2 of Radial Club Hand Talk. As we said earlier, we are going to talk about surgery. Contraindications to surgery. The only absolute contraindication includes incorrectable elbow stiffness, which will prevent the useful use of the hand for feeding or self-caring. So, and the other absolute is unacceptable anesthesia risk. Relative contraindications are firmly established functional patterns in older patients where surgery might disrupt the already developed function. Mainly, we need to balance between the cosmetic gain and functional gain, and between the losses that we are going to encounter and the prolonged physiotherapy. So that's why it is in the relative contraindications. Another relative contraindication is a mild deformity with acceptable cosmetic status and function, where we don't need to intervene. All the radial forearm structures are aberrant or absent to varying degrees. This includes bones and joints, muscles and tendons, ligaments, nerves, and blood vessels. So we are not dealing with just bony correction. And this is important in surgery for surgical precautions during the procedure. Some of the predictable anomalies include absent or aberrant radial wrist extensors and extrinsic thumb motors. The presence of radial anlage, which needs to be released during the surgery. The absence of radial nerve below the elbow, which will be in part overcome by the median nerve, which is always present, and it is the most prominent structure on the radial side of the wrist and needs to be protected from injury. And the radial artery is also absent, so we rely on one artery to supply the hand. The aim of improving function and appearance should be always kept in mind and never forgotten. There is no established solution. The solutions range from simple soft tissue releases or complex soft tissue releases around the wrist to the classical centralization with or without tendon transfers and with or without osteotomies, and with the newer modifications of radialization and ulnarization, which are similar but differ in the approach and the place of centralization. The addition of external fixator distraction prior to centralization procedures, or without the use of centralization, relying solely on the external fixator for bone lengthening and distraction. The free microvascular transfer grafts using toes or proximal fibular transplant. And finally, the arthrodesis, which is usually in adults with for cosmetic reasons and minor improvements in the function. Type 0, 1 or mild type 2 usually require only stretching and splinting. The more radial deviation we have, the more soft tissue releases and tendon transfers we will need. The best results of surgery usually are obtained when it is done before 1 year of age and with a combination of tendon transfer. The first step in the surgery is to plan and design the skin flaps and the soft tissue releases. This design will depend on the amount of initial correction obtained by different methods and the amount of redundant skin left in the ulnar side after we finish. Simplest is longitudinal Z-plasty on the radial side with a transverse incision on the ulnar side. Modified lazy S or C dorsal midline incision has been used. The more accepted and used flap nowadays is the bilobed incision, which allows no tissue loss from the ulnar side, and the whole redundant soft tissue will be shifted to the radial side where it is needed. And there are new arguments about dorsal versus volar incisions or a combination of both, with proponents for each approach. Especially the volar approach opponents indicate that they can visualize more the structures and they can protect them easier. Centralization, radialization, ulnarization, all of these aim to create a fulcrum to radial deviation forces of the forearm and muscles while not impeding the wrist motion and balancing the tendon transfer forces on the radial and ulnar sides. The centralization is where we put the ulna in the center of the carpus. The radialization was proposed originally in German, and it does not mean that we put the ulna radially. It means that the ulna is becoming a radius. So basically radialization and ulnarization are similar in terms of putting the ulna in the maximum ulnar position to correct the radial deviation of the wrist. Tips during the surgery. The main thing is, as we said, the aberrant anatomy. So we need to preserve all structures. One of the important ones is the dorsal ulnar sensory nerve. K-wire should be used, and the size should be big enough to fill the metacarpal space before entering into the ulna. There should be no more than 2 attempts used to go through the ulna in order to protect the ulnar growth plate. If the ulna is not accepting the K-wire, we can go for osteotomy. And the osteotomy site is usually where the wire is exiting from the ulnar curvature. And this is the maximum core of the deformity, if needed. Some people do the ulnar osteotomy routinely with every procedure to maintain their correction. The carpectomies and central position of the ulna are fading in favor nowadays, and the more acceptable positioning is under the radial carpal bone or to articulate with the scaphoid. These all aim to protect the growth plate of the ulna and make it useful for future growth of the forearm. Tendon transfers. All the aberrant wrist extensors that are available, the external carpi radialis, longus and brevis, brachioradialis, flexor carpi radialis, all are used to be transferred to the ulnar side in order to balance the ulnar forces with the radial forces. Paley advises FCU transfer over the FCR transfer that was originally described in the radialization procedure. He says that the FCU is more constant while the FCR sometimes is absent, and the FCU will provide the necessary balancing force when attached to the base of the fourth metacarpal. When using an external fixator, the application of pins should be always by the open technique and in the following proposed positions. The use of external fixator has reported less neurovascular compromise and recurrence of the deformity, less non-unions or needs for bone grafting if osteotomy is used, and the wound infection and osteomyelitis is not a major concern with external fixator. Also, it has an advantage that it can be used in older children, especially those who are above 12 years of old, who have already a functional pattern developed and need a slight modification of limb length and stability. The toe transfer concept of Velke is a complex microvascular surgery needing lots of complicated techniques and surgical skills. It gives good results, but however, sometimes it is not as much more different from the regular policization procedures used for the thumb creation. Post-operative management, the cast should be applied for no less than 2 months. Some people go to 3 or 4 months. The pin that is used for centralization and policization should be maintained as long as possible. Some people would advise keeping it indefinitely buried in bone without attempting extraction. This has the disadvantage of sacrificing the wrist mobility and wrist movement and ending up with a stiff wrist that might add to the forces of the grip of the fingers. A longer arm stent, which is custom made to position the wrist, is used full time for for a total of 3 to 6 months, and then indefinitely or at night. The complications, the most prominent complication of all procedures is the recurrence and correction loss. This is the devil of all radial club hand surgeries. None of the authors have ever reported no recurrence at all, while newer techniques, especially with Bailey's centralization and external fixator, is reporting less rates of recurrence than the others. But this needs more time to judge and more sample size to judge more on it in the future. Other complications are usually related to cast, including pressure sores, dermatitis, related to flaps with marginal necrosis and infection, and these are usually easy to resolve. Related to external fixator, where we have pin tract infection or fracture in the regenerate zone when we remove the external fixator, but usually these do not require further surgical intervention. The distal ulnar epiphysis related complication, whether it is a growth arrest or avascular necrosis or an overgrowth with excessive ulnar deviation, and this was especially true with the use of external fixators. The wrist-related complications, where we end up with an unstable wrist or a spontaneous arthrodese wrist. It is either stiffness or either instability. Usually the wrist is not restored back to normal. Finger stiffness, this is always the case, and the stiffness is always reducing as we go ulnary. So the more radial digits are more stiff than the ulnar digits. The KY related complications of extrusion or migration, which might necessitate a second procedure and repeat of the operation. Going to the thumb and giving it special consideration in radial club hand. As we said earlier, we classify it, the main determinant is the stable CMC joint. Usually with type 1 thumb deficiency, we require no treatment. In types 2 and 3A, some form of reconstruction, muscle transfers, tendon transfers, or balancing should be used. When we have unstable CMC joints in types 3B, 4, 5, we go usually for policization or the microsurgical joint transfer. However, policization has proven good results with good follow-up times, and contrary to the microsurgical joint transfer, which has the added complexity of the procedure and doesn't add really to the policization gain. As we said earlier, in type 2, the components that might be needed to be addressed are the openoplasty, first web release, and the ulnar collateral ligament reconstruction. We'll go into details. The steps in thumb reconstruction. First of all, the narrow index web space, if it was mild, release of first dorsal interosseous fascia with Z-plasty, or a 4-flap design which gives more rounded contour might be all what is needed. If the narrowing of the index web space is moderate, the release of first dorsal interosseous muscles should be added from the second metacarpal with a dorsal rotational advancement flap to cover the defect. The ulnar collateral ligament insufficiency should be addressed, whether it is primary or secondary to pollex abductus. And here it is important to release the pollex abductus abnormal connection between the FPL and EPL if it is present. And usually the ulnar collateral ligament reconstruction is combined together with the openoplasty, and sometimes the same tendon that is used for both. The absence of intrinsic thenar muscles. Here we need the openoplasty, which is the preferred tendon transfer. Usually the 4th FDS transfer with an FCU loop to the base of the thumb is the method of choice. However, some other reports report the use of abductor digiti minimi or extensor indicis proprius. Extrinsic musculotendinous abnormalities of the EPL or FPL tendon or both. Here we need to transfer at the initial thumb reconstruction procedure, or we can do it at a delayed staged procedure later on. The index indicis proprius is used to the EPL, and the FPL is the more difficult. Sometimes the tendon sheath might be deficient, where we need to do poly reconstruction, tendon centralization, or tendon transfer, or even both are required. And no matter what you do, the end results are usually not satisfying in terms of FPL function. Policization. The outcome determinants of the procedure of policization depend on the status of the index digit. If it is stiff, it will be stable for the gross grasp, but not the pinch grasp. If it was mobile, it will give better results with stability of both the gross grasp and the pinch grasp. The surgical technique has a very important role in the success of policization, where most of the complications of policization usually are related to the surgical technique, and in most severe forms might even result in gangrene and loss of the thumb that has been policized. So attention should be to every minor detail during the policization surgery. Presence of associated radial club hand or without radial club hand. Usually the thumb policization without a radial club hand deformity gives a better predictable outcome. The steps that we need to take care during policization begin from the S marking, which aids to visualize the vasculature, proceeding to skin incision to create the adequate flaps and plan them well, proceeding to identification of all major neurovascular bundles, digital nerves and arteries, and steps to prepare them for the transfer procedure. We need to sacrifice the proper digital artery to the radial side of the long finger to improve the blood supply to the newly constructed thumb. Pulleys need to be released. Elevation of skin from volar incision should be done to the dorsal veins, and another dorsal wound might be needed. The extensor tendons need to be freed with the flexor tendons. However, they should not be sacrificed because they will shorten with time. The elevation of the interossei muscles is important, and while some surgeons leave them without a reattachment, it has been proven that reattachment gives a better functional outcome in the future. So this detail should be kept in mind. The radial and ulnar lateral bands around the PIP joint provide important pull on the lateral design function of the, so a suture should be put in them to aid in their tension and keep the tension as desired. The CMC joint of the index is provides a function of hyperextension, while the thumb CMC joint is stable. So this needs to be compensated by hyperextending the transferred CMC joint and fixing it to allow for a proper thumb base stability. The K-wires should used after osteotomizing the metacarpal or the metacarpophalangeal joint, whether it depends on the surgeon preference on which level he will do the osteotomy. And then the final alignment of the index should be maintained in 45 degrees of abduction and between 100 and 120 degrees of pronation at the level of the interphalangeal joint of the adjacent finger. And finally, we need to deflate the skin, the tourniquet after skin closure to make sure that there is no vascular compromise whatsoever of the arterial or venous side. The complications of the policization procedure are early or late, and as we said earlier, early are usually delayed arterial compromise or transient venous problems, and these should be dealt with on table immediately in the surgical room before transferring the patient to floor. And if venous problems happens, elevation, revising the back slap and the compression should be done until we are sure that the circulation is 100% adequate. Late complications usually include first web space contracture, stiffness, excessive length, malrotation, lack of opposition. All of these, as we said earlier, could be avoided by meticulous surgical technique. Thank you for your attention, and hopefully we'll meet again in future seminars and to tackle other topics of hand surgery. Thank you and see you soon.